October 2023. Next slide. So these are some of the key indicators which we have improved perception during implementation among the communities in participating in the dialogue. As I said, you know, the adherence of the communities in the activities being implemented and the level of ownership has been tremendous. Next slide. So this is just to describe, I hope you can see the map of Cameroon, and the dark point, the top point is the far north region. And you can see that the bordering of in the west of Nigeria, in the north Niger, and on the east Chad. So the COSA is the Comité de Santé in French, or a health committee. The project is implemented through those fora, which are kind of interface between the communities and the health facilities, and they play an important role whether or not there is a conflict. They can really serve as a basis for strengthening social cohesion. The next slide is about an experience you have seen actually in the video. Is this example where in Zamai, about 682 ex-associates, and this is from the latest data from IOM, which has the expertise in this area, who have arrived from several waves of defection from the armed groups, the non-state armed groups, since 2018. And of late, they were living isolated in IDP camps with high level of community stigmatization and socio-economic needs for reintegration. And through this project, a member of this ex-combatant were able to integrate the Comité de Santé or health committees, and they contributed, became a full members of these committees, and played a role in providing health services. And I believe my brother Ben Umar will be able to say a bit more about this. So this is what the lessons learned for us is that this is really proof of concept, and it is going to be to serve other needs. For instance, the country has just adopted a community health strategy. So this project is able to show that when you engage in a meaningful way, the community through their structures and the leaders, and also providing needed services which are expressed through their plans, you can achieve good results. The country also has just launched in April the phase 1 of the universal health coverage strategy, which is again going to provide essential services to community, and this region is a priority region for this initiative. So we believe that the lessons we are learning are going to be useful even when resources are made available to go to scale. The big challenge is that when you interact with communities, their needs go far beyond the health sector. So it is important to have a multi-sectoral approach to be able to address all their needs beyond the health sector. So I'll stop here and pass the floor to Ben Umar for his intervention, and then we'll be able to continue our briefing. Ben Oumar, vous avez la parole pour 8 minutes, s'il vous plaît.
We cannot hear you.
I can't hear you, Ben Omar. Can someone else hear Ben Umar?
Not yet. I think they're working on it.
Colleagues, maybe in the meantime, while the colleague from the far north government fixes the audio, maybe I'll go and speak a little bit for the IOM section of this program and what we've brought to it. And hopefully our colleague from the far north governor's representative can come in after that. So my name is Liam Perry. As my colleague Dr. Fenwell mentioned, I'm the Senior Policy and Program Officer for IOM. I'm based in New York, and I do the liaison with in this case, our donor, the Peacebuilding Fund. I incidentally also was in Cameroon when the government of Cameroon did the request to the Peacebuilding Fund for its eligibility back in 2019. So it's kind of nice to see how this project has come along and is part of that broader envelope. I'll just maybe touch upon a few elements of the context to kind of link it to what I'm going to say in terms of how IOM started this discussion with WHO and how we see the kind of link to the broader context of what's going on in Cameroon. I won't rehash what Dr. Fenwell explained about the Boko Haram conflict, which I guess most of you are familiar with. But I will just emphasize on the point that it has displaced a huge number of people across the Lake Chad Basin. And for the far north, we estimate that there's been approximately 3,000 Cameroonians that have been affected in terms of being killed during the fighting, and about 250,000 displaced. And this has triggered also a lot of a rise of vigilante groups and a lot of violence in and around the conflict. But then I think Dr. Fenwell also mentioned that there's ongoing tensions in communities there between farmers and herders, also due to the negative impact of climate change. So a very difficult context that's also been affected by historical underdevelopment. The far north region is by far the most poor in Cameroon, with a poverty rate of about 74% of the population living below the poverty line, versus the national average, which is around 37%. So just to kind of give you also a perspective that this kind of chronic underdevelopment of that part of the country has translated into suboptimal kind of service delivery. There's been a lack of education opportunities, employment opportunities for particularly youth, and that has been part of the factors kind of driving some elements to join armed groups in the far north of Cameroon. So from IOM's side, I just wanted to emphasize that displacement aspect, because we're the UN Migration Agency, and so for us, working on the prevention of forced displacements and their resolution is really our raison d'etre in this type of context. And so it was at this opportunity that was established through this request from the government of Cameroon to assist it in working on decentralization, on vivre ensemble, which is kind of better cohabitation, living together, which are two of the priorities actually that were part of this initial request to the Peacebuilding Fund. We saw an opportunity there to work with our colleagues from WHO and from the Department of Peace Operations to find entry points at the community level that would allow us to assist authorities to become more present, more relevant, and ultimately more legitimate in the eyes of the population by being able to deliver better services in the far north. And so we've had the pleasure of working with WHO on this under their Global Health for Peace initiative for developing this intervention. And we found very complementary kind of expertise in our organizations, with WHO having a strong and long-standing ties with the Ministry of Health, and its obviously technical expertise in the provision of health services, building institutional capacity and changing also organizational cultures in the health sector. For us, as the migration agency, as I mentioned, like in these unstable contexts, we really try and work with authorities, communities, to try and prevent forced displacements, in this case due to conflict, but it's also a context, as I mentioned, that's affected by climate change there. And so to reduce sometimes the zero-sum games that may come out of these negative impacts of climate change, and notably the farmer-herder conflicts in this case. So we've been working for over 30 years in different parts of the world to act on these drivers of forced displacement and prevent them through community stabilization, peace building, DDR programs, so disarmament, demobilization, reintegration programs, and supporting our member states to do that. We are also, maybe we would like to pride ourselves as a UN entity for being quite operational and able to be present not only through this type of program, but also our humanitarian programming in these very hard to reach, unstable contexts. And so I think that partnership with WHO was really beneficial for both organizations in this case. From a mandate perspective, IOM, as I said, like really sees this as part of its core mandate to address the factors that are causing forced displacements, and to look at strengthening where possible, when return is possible to the communities of origin, all the factors that will enable that return and reintegration of people, whether they be just civilians that have been displaced by the fighting, or former associates of armed groups, and accompanying in a way the reconciliation, transitional justice processes that that are needed actually in these kind of contexts for that reintegration to happen. And for that, we've also very much benefited from that partnership with the Department of Peace Operations and their expertise in disarmament, demobilization, reintegration. So for IOM in Cameroon, in this project, we've really brought forward our community stabilization approach, and its focus on addressing those latent kind of drivers of fragility, and the negative kind of impacts that the conflict has created between communities in the far north, between displaced communities and host communities, between former associates of the armed groups that are in or outside camps, and communities living around these camps. So we were really trying through this project to have an innovative approach to find entry points, to rebuild that trust, to rebuild that dialogue between them, and at the same time also look at some of the factors in the context where we were working that were at the root cause kind of the instability up there. So providing better services, but also rebuilding that social contract between the government and the people of the far north, the government of Cameroon and the people living in the far north. So we were really aiming to restore social cohesion between communities and that social contract with local authorities. And for that, we've developed in several contexts kind of flagship methodology that we use, and I'm sure other organizations do something similar. It's kind of I think a globally recognized best practice now that to build peace, it cannot just be a top-down process, and particularly in these contexts where there's been center-periphery issues between the government maybe not being present or not being able to deliver services to the level that is needed to the population. And so we really thought that our community-based planning methodology would be appropriate there. And I'll just explain briefly what that community-based planning methodology is. Thank you for following with the slides. And this slide just gives you a bit of an overview of the different phases of the community-based planning methodology. I won't get too technical, but I'll just kind of explain its main components, really. The community-based planning methodology looks at it's a step-by-step approach to cover planning, assessments, and recovery phases of a program operating in an unstable context. And the outcomes of the community-based planning is usually the equivalent of a local development plan, essentially a way that there's dialogue that we can establish around the community-based planning methodology by bringing affected communities, service providers, and local governments together, and sometimes even security providers around this discussion, is to create an inclusive planning process through which the community can voice what are their priority needs that need to be addressed, and the government can also be an interlocutor for this, and also say with the means that they have what can be provided. And in this case, of course, there were means provided thanks to the Peacebuilding Fund, but it could also be humanitarian development or other kind of external funding that could be channeled to respond to the priorities that come out of these local development plans. And so on the basis of this community-based planning or local development plan, or we call them community action plans in certain cases, we're able to mobilize the community towards identifying the priority elements in their communities. In this case, it was very much around health, provision of health services, rehabilitation of health infrastructures, but it could also be other things. It could be, for instance, the need to rebuild a well, or rehabilitate a local market, or anything that would enable the community essentially to recover and move out of a humanitarian kind of dependency to humanitarian handouts, and become more, as they said in the video, autonomous, self-sufficient, because that, at the end of the day, is what we're there to do, is to not be there anymore. We're not supposed to be there ad vitam aeternam. We're really trying to work with the authorities, with the communities, so that they can be as self-sufficient as possible in doing this. I think I could maybe...
Liam, please sum up.
Yeah, I can just maybe end there with that, and can take some questions during the Q&A. Thank you very much.
Thank you, Liam Perret, for this good introduction of the work. Now I would like to call upon Mathilde Bodard, who is going to give us an overview on the Global Health for Peace initiative. Mathilde, you have the floor.
Thank you very much, Dr. Faniel. Good morning, everyone. Pleasure to be part of this event today. I work at the WHO at headquarters, and I'm the technical lead on the Global Health for Peace initiative. Yes, we've been collaborating very interestingly with the International Organization for Migration and the UN Department of Peace Operations on this project. And there's some history behind this at global policy level that I'm here to tell you about. Is it possible to share slides that you should have on this from our side?
Please show slide 21. Yeah, excellent.
Excellent. Thank you so much. I suppose I don't have access to changing slides, right? Can I just ask you to change them for me, please?
You just need to run through quickly.
Okay. Excellent, thank you. WHO has launched what we call the Global Health for Peace Initiative in 2019. And that's really the background behind this project that takes place in Cameroon at policy level. The objective of that initiative is really to strengthen the role of WHO and the health sector as contributors to peace outcomes, such as social cohesion, dialogue, resilience to violence, while empowering communities, as Liam has just illustrated it and Dr. Fanuel earlier, in the framework of WHO's mandate. The ultimate objective for us in doing so is, of course, not just to contribute to peace outcomes given WHO's mandate, but to do so while, of course, improving the protection of health of population, the health protection of populations in FCV countries, as we call them, fragile, conflict-affected, and vulnerable countries or settings, and in wider settings globally. Meaning, this initiative does not just apply to open conflict settings, but also to settings where there is a need for improving social cohesion, where there are underlying tensions, or most importantly, also in post-conflict settings. So really, to give you the broader picture, this is what we are talking about. Let me see if I can change slides. Is this working on your side? Yes, it is. You can see that on the screen. Excellent. Why is WHO talking of health for peace? I think in the video somebody said this. The WHO project manager actually mentioned this. Indeed, it is a relevant question. The reason why WHO has embarked on this, I mean, there's many. The first one comes from the realization that much of WHO's humanitarian caseload, about 80%, and about 70% of disease outbreaks that WHO responds to actually take place in fragile, conflict-affected, and vulnerable settings. This means that we cannot continue working in a way that is almost conflict blind would be a very strong word, but in a way we cannot just look at our health mandate without taking the time to pause and look at the peace and conflict factors that are active around us and how we might interact with them. So that's one realization. It's really it's most of the context we operate as far as WHO's humanitarian branch is concerned are in fragile, conflict-affected, and vulnerable settings. So we need to look at those issues quite critically. One of the other reasons is quite factual. It relates to the links that exist between health and peace. Negative links, positive links. Of course, not telling you anything new here, but conflicts cause, of course, increased death and injuries, diseases, malnutrition, while leading to breakdown of health systems. Further, what we also notice is that the inequitable or the discriminatory provision of health services can be a conflict factor and contribute to fueling conflicts, as any other inequitable access to basic services in general. On the other hand, there are also many positive links, and I won't elaborate too much on this, but basically we see that health can be an entry point for contributing to some peace outcomes if it is accessible in an equitable manner, or it can be an entry point that looks sometimes neutral, although we don't really like using this word because it's quite loaded politically, but at least it can be seen as a common good that brings different parties around the same table in some cases. So there is an opportunity that can be seized here, and this is what we're trying to do. This is a famous quote of WHO's Director General about this, who often says that there cannot be health without peace, and there cannot be peace without health. Two sides of the same coin, and of course, WHO is hoping to contribute to both. Last but not least, and maybe here I want to point out one major policy and agenda at global level that also justifies this initiative, which is the Humanitarian Development Peace Nexus and the UN Sustaining Peace Agenda, the two being very connected. In a way, one could argue that the Global Health for Peace initiative of WHO is WHO's contribution to the triple nexus, or at least part of its contribution at global policy level, and then it needs to be implemented at country level. And also its contribution to the UN sustaining peace agenda. So, and many other policy, there's many other policy backgrounds. There's also much to say about the policy background behind this initiative, but you can see this on the screen. I would like to now move on to maybe telling you a bit more about what it is in practice. What we call Health for Peace programming basically relies on two key components to it. And this project in Cameroon is a very good illustration of this. It is right into this. So there's three components, as I said. First, of course, an improved understanding of the context by WHO, by its partners, when it comes to peace and conflict factors. And based on this, what we say is WHO can do and must do conflict-sensitive programming. Doing no harm is not a new principle, but now we want to probably be a bit more systematic in applying it in conflict-affected settings or other settings that have some social cohesion issues and sensitivities. Second, the Health for Peace approach to programming says, okay, where possible, when appropriate, because we're also aware that it may also sometimes have bring some risks, either for beneficiaries or for WHO or health workers and others, where appropriate, where context allows, let's try and contribute to some peace outcomes. Let's do some peace responsive programming, as we call it. And that's really context specific. There's no one size fits all approach. Every country can have has to identify and determine how health programming can contribute to peace outcomes. And again, we're here to talk about the Cameroon project. Some of the peace outcomes that we are pursuing here. And sorry, this is another slide I wanted to show quickly, but just insisting on the fact that we're not talking of necessarily peace at political high level, but peace at community level, social cohesion level. Moving on to what I was trying to illustrate, the type of peace outcomes that this project and other projects are trying to achieve really are such as reducing exclusion, building trust between citizens and the authorities, or building trust between and within groups in the communities, reinforcing social cohesion, facilitating rapprochement and building trust sometimes between parties to a conflict can also be a possibility. And on the right side of the screen, you can see different types of activities that can contribute to those outcomes through health programming. I will move on because I've already mentioned this, that this is not just about conflict-affected settings, but also other settings. Yes, the Global Health for Peace initiative has been launched quite a few years ago now already, as I've mentioned. And there's a few countries where this approach has started being implemented. In Somalia and Sri Lanka, although this was even prior to this initiative's launch, but that's with the same spirit where they've used mental health and psychosocial support interventions to try and contribute to peace outcomes, such as reconciliation and preventing youth violence. In Cameroon, we're here to talk about this, and sorry for the spelling mistake, it's a very bad one. And we've also got other examples of health for peace projects, as we call them, in Burkina Faso, in Guinea-Bissau, as we speak, with the support of the Peacebuilding Fund. All of this being implemented with other partners, and that's, I think, my last slide. Here on the screen, you can see the different work streams of the Global Health for Peace initiative. Evidence generation still is very important to us. There are good practices that have been identified already, but more needs to be done and feed into the development of this approach. We need to continue strengthening capacities, et cetera, and basically mainstreaming this approach into WHO programs. But as I was saying, all of this is not possible for WHO on its own. And this is why in this case, as we illustrated, we decided to partner with agencies or entities of the UN, such as IOM and Department of Peace Operations, because we want to learn from one another on this, on implementing the UN Sustaining Peace Agenda and the Triple Nexus. And we want to benefit from their expertise in peace building. In Guinea-Bissau, we also have a project with the International Peacebuilding Organization, Interpeace, and with UNICEF. And we want to continue developing GHPI implementation in this direction. This is it. I'll hand over to the room, and happy to take any question on the Global Health for Peace initiative during the Q&A session. Thank you very much.
Oui, Dr. Franuel, après ces soucis techniques, je suis déjà en ligne. Est-ce que vous m'entendez?
Oui, nous vous entendons très bien, Benouma. Donc, si vous êtes disponible, prenez la parole pour 5 minutes, s'il vous plaît.
OK, merci bien, Dr. Franuel, pour la parole donnée. Très chers panélistes, honorables participants, mesdames et messieurs, je mesure l'honneur qui est le mien de prendre la parole en présence des panélistes de haute facture pour échanger sur le projet intitulé « La santé au service de la paix, consolidation de la paix et réduction de la violence dans les communautés de l'extrême nord grâce à des interventions sanitaires, sociales inclusives ». Ce projet, financé par les fonds de consolidation de la paix des Nations Unies et implémenté conjointement par l'Organisation mondiale de la santé et l'Organisation internationale des migrants dans la région de l'extrême nord République du Cameroun. Le statut de mon exposé sera articulé autour de 3 points essentiels, à savoir le dispositif gouvernemental de coordination, les comités de santé comme structure d'ancrage du projet et les perspectives gouvernementales de pérennisation. Depuis 2012, la région de l'extrême nord est entrée de plein pied dans une crise sécuritaire aiguë, orchestrée par la secte Boko Haram et dont les séquelles sont loin d'être oubliées. Face à cette situation, le président de la République du Cameroun, le chef de l'État, a engagé avec l'appui des partenaires du système des Nations Unies une coopération vigoureuse qui a abouti à l'éligibilité du Cameroun au Fonds de consolidation de la paix, puis l'extrême a bénéficié du projet mentionné. Ainsi, le gouvernement de la République du Cameroun, pour assurer une meilleure coordination de ces projets et de l'ensemble des interventions financées par le PBF sur son territoire, a mis sur pied un comité de pilotage au niveau national, présidé par le service du Premier ministre, où l'on retrouve tous les membres du gouvernement concernés par le dit projet. Au niveau régional également, un comité local de suivi est créé et présidé par le gouverneur de la région de l'extrême nord, dont les membres sont constitués de sectoriels, y compris les responsables des agences de mise en œuvre du système des Nations Unies. Ces deux instances de coordination assurent le suivi quotidien des activités, évaluent le niveau d'exécution et formulent des recommandations correctives éventuellement. L'État, à travers ces instances, veille à l'effectivité harmonieuse des activités afin d'atteindre conséquemment les résultats souhaités. Ces projets rentrent en droite ligne des orientations stratégiques du gouvernement, d'où son implication à tous les instants. Le projet intitulé a pour porte d'entrée les comités de santé, c'est-à-dire les COSA, qui sont une structure de dialogue très bien organisée, qui joue le rôle d'intermédiaire entre les aires de santé et la communauté. C'est une structure qui a une bonne réputation et de l'aura au sein de la communauté. Elle est dotée d'une expérience avérée dans le domaine de l'action humanitaire et qui sait trouver le trait d'union entre la santé et la paix. D'où le choix stratégique de cette structure comme point d'ancrage de ce projet. Au-delà de ces missions classiques sanitaires, elle est dotée également des missions de la promotion de la paix, du vivre ensemble, de cohésion sociale, de la promotion du genre, de la réduction de la marginalisation et du développement. Dans ce registre, nous avons organisé une série de formations pour renforcer les capacités des membres du comité de santé en mettant un accent tout particulier sur leur cadre juridique et facilitant ainsi leur existence dans l'ordonnancement juridique. Les perspectives stratégiques du gouvernement dans le cadre de ce projet sont la pérennisation des acquis qui se feront par le biais de la décentralisation. Ainsi, au terme du projet, les communes vont se substituer aux humanitaires et continuer à encadrer les comités de santé afin de pérenniser les acquis et poursuivre la sensibilisation dans la communauté sur le bien fondé. Cette phase déterminante nécessite une formation préalable sur la preuve méthodologique, la collaboration entre les acteurs communaux, les membres de COSA et le personnel de santé pour une synergie harmonieuse d'action. Vous allez voir l'implication du gouvernement dans ce projet et à tous les niveaux. Nous, au niveau local, le gouverneur de la région de l'extrême nord, dans le cadre d'apporter les éclaircies sur le cadre juridique au COSA, nous a conviés, nous a instruits de former les COSA, les membres du COSA sur le cadre juridique afin de leur permettre de mener à bien leur activité. Nous avons mené cette activité en compagnie de l'OMS, de l'OIM et également le Fonds national, le Fonds régional de la promotion de la santé. Ça a été un succès et ça a permis vraiment au COSA d'avoir les outils nécessaires pour mener à bien les objectifs à eux assignés. Donc, vous allez également vous rendre compte que c'est un projet qui a un impact favorable parce que toutes les couches vulnérables cibles sont touchées par ce projet et on ne peut que s'en féliciter. Donc, pour clore mes propos, au regard du temps imparti, je voudrais témoigner toute notre gratitude et notre reconnaissance à la communauté des partenaires financiers dont la générosité constante a procuré toute sa consistance et l'impact recherché dans le cadre du projet PBF, dont nous espérons vraiment que vous continuerez à financer ce genre d'initiatives louables et nobles. Si il y a lieu, nous allons revenir sur la phase de questions-réponses pour garnir davantage notre intervention. Merci.
Thank you very much, Ben Umar, for your briefing, which highlighted the strong support of the government of Cameroon to this project, both from the national level, with the president of the steering committee sitting in the office of the Prime Minister, and also at the regional level, with the strong involvement of the governor, who I have met personally and who launched the project. I was at the place of launching, and also a very good experience of developing the legal framework for health committees. So I think this is something very significant, which can be duplicated in other regions if it is not yet the practice. So thank you very much for your intervention. I want now to move to Kwame Oku, DDR Policy and Planning Officer at the Department of Peace Operations in New York. Vous avez 5 minutes, mon cher frère.
Merci beaucoup. Good afternoon and good morning to those of you online as well. As was mentioned, my name is Kwame Poku, team lead focusing mostly on DRC and the Great Lakes, but section lead on health and peace. I'm going to wait for maybe the slides to pop up if you can. But while you do that, I'm just going to, my main...
So that will be slide 36, please. Slide 36.
But my main task will be to give you the third circle in the Venn diagram that we've been trying to draw out, which is to say that if you've been wondering why a peacekeeping organization is working on a peace building project, that will be my attempt to answer. Here I would need the slide, if possible.
Slide 36, please. Please pop up the presentation and show slide 36. Yeah.
Next one,
Thank
please.
you. That's remarkable.
Next slide.
Next slide. This better be the best slide ever. There we go. And it's not. But as you've heard, DDR, disarmament, demobilization, reintegration, I won't bore you with too much of the details because I don't have enough time to do that. But essentially what we work on, our raison d'etre from the global level, is on finding solutions to dismantle armed groups through non-military measures. Essentially that's our prime mandate. And we do so across many various objectives, essentially the prevention of recruitment of youth, support to mediation and peace processes, curbing the use and impact of weapons. So this is more on the demobilization and disarmament side, and of course the reintegration, which is the big piece, which is the supporting members of armed groups to return to civilian life. Next slide. So all of this is underpinned by two core pillars, policy and practice. We have something called the integrated DDR standards, which are international standards that have been developed by all of the 27 or so agencies that you see below you, including WHO and IOM, of course. The modules in here, there's about 35 of them, 36, that cover a whole host of issues around misinformation and disinformation, the natural exploitation of the illicit exploitation of natural resources, armed groups designated as terrorist organizations. But of course, why I'm here is to give you a sense of the piece around health, which is why we are so excited to contribute to the Global Health and Peace Initiative that WHO is leading, because we very much see a lot of entry points between what that work is and what our aim is, which is, as I've mentioned, to dismantle armed groups and elicit voluntary exits. So that's essentially the policy, and you'll see the practice side. I started off with a little picture of what it looked like in 2006, and this is what it currently looks like now. And we've gone from about 8 or 9 settings to right now about 28 that our section covers. And this is the answer to why a peacekeeping operation is doing peace building now, peacekeeping institution. And that's because our mandate has evolved, and it's evolved for the same reasons as Mathilde had mentioned. We're seeing more and more, fewer and fewer peace agreements. We're seeing more and more fragile peace agreements, localized violence, regionalized dynamics, and this has forced us to move away from our classic DDR approach, which only focused on peacekeeping operations and special political missions as mandated by the Security Council. And now our mandate and our remit has become much more broader, which means we now get to support our sister agencies in settings where there's no where there's no Security Council mandate, which we call a non-mission setting. And here you can see them in red: Cameroon, Côte d'Ivoire, Burkina Faso, you name it, we're there. We're the same objective in mind, which is to disarm, demobilize, and eventually reintegrate members of gangs and armed groups. Next slide. So zooming in into the peace part, there's 4 main pillars, which I'm quickly going to run through, some of which you'll see are hallmarks of the Cameroon project. But again, as I mentioned, I'm going to give you a bit of a global perspective, so I'll be drawing from other settings that we are implementing this global program of work that we call Health and DDR. But of course, informed by the Health and Peace Initiative, which is why we're here. First pillar is around health system strengthening. This is an example from Central African Republic, for example, where at the reintegration stage, we're leveraging ex-combatants who are about to return into communities to build and rehabilitate critical facilities, in this case health facilities. And this is double impact, not only improving the health infrastructure, but also as a means of reparation as they seek to transition from combatants to civilians. The second piece is what you've heard many times already around the COSAS, which is essentially piggybacking on community forums. And you heard them very clearly, the previous speakers. It always starts with health grievances, but invariably grows to more. And this is where this linkage between our work and the health work becomes even more important. The second pillar is around mental health and psychosocial support. Again, hallmarks here are visible in the Cameroon project, but also, and this is where this picture is from, which I took 4 weeks ago on the border of DRC and Uganda. And these are not children that are dependent on an armed group. These are actually ex-combatants, if you can call them that, which is unfortunate. And these 4 are from the ADF, an armed group operating in the east of DRC. The oldest person you see here is 12, and he was a commander, if you can call them that. So I think it's obvious that the psychosocial part of it, but not only for the trauma, but obviously we're now seeing a lot of results related to the use of psychosocial support and the reduction of recidivism, the so-called revolving door. Next. Third pillar is health workforce, and here again, something that we're trying to test out in Cameroon, but we've done elsewhere. Here, Colombia is the main example, and this is around analyzing the preferences of ex-combatants, their wills, their hopes, their dreams. Some of whom want to go home and be, farmers, but some of whom want to reintegrate into the health system because that is the function that they were playing in their armed group. And so, for the FARC, for example, we were able to identify ex-combatants with health expertise and integrate them into the health system. And again, many examples that I can always touch on during the Q&A. And quickly to the last pillar, which is on infectious diseases and outbreak settings. And this is less on the downstream DDR and more on the upstream, which is to say mediation with armed groups. And sometimes contexts are so politically charged that it's very difficult for us to support a mediation process between national authorities and armed groups. And so we've seen, as has been mentioned by multiple people who spoke before me, this neutrality, I know Mathilde didn't like the word, but maybe a political nature of an outbreak or a health crisis that allows us to sort of a Trojan horse of a mediation moment where we get to discuss with armed groups and then begin to piggyback some confidence building measures, and the main one of which is unconditional release of children. I've gone through this way too fast, just in the interest of time, but these essentially are the 4 pillars that have made us so excited to test out with WHO, with IOM, in peacekeeping operations, peacekeeping settings, but also, as I mentioned, in non-mission settings such as Cameroon and others. So I'll leave it there and thank you for your attention.
Thank you very much, Mr. Kwame Poku, for this excellent presentation. I think everyone in this conference will remember this dramatic picture from you have shown us at the border between DRC and Uganda, and the kind of job description you gave to these children. So now it is time for question and answer. So I believe we have a moderator who is asking question, and then pass the microphone to the person, and then we'll be able to see how we progress. Christian, can you help pass the floor to whoever is asking for question or comment or contribution?
Sure. On the virtual side, it looks like there's one question that's been submitted. Where could we learn more about your mental health and psychosocial pillars, including activities and how they are monitored? I believe that one was for the last speaker.
No, thanks. Great question. I think that's essentially one of the hardest things to monitor because it's a bit more longitudinal. But we try and embed all of our M&E through the implementation of hopefully what is a national DDR program or DDR policy. So in that policy, you would have a number of key outcomes and outputs and inputs. And that's where we would monitor such progress, but not just for the ex-combatants, but we have something called a 1+3 approach, which is for every ex-combatant, we also try and provide the same service for community members so as to reduce the likelihood of grievances and for us to be seen as only, providing benefits to ex-combatants. So again, I think going back to the partnership, this is why we're so excited again to partner with WHO and IOM, because agencies, funds, and programs also have direct access to line ministries. And so the part of our interventions that focus on communities, that M&E also happens on that side. And I don't know if you want to.
I could just add a couple of points from IOM side, and it's not my area of specialty, but we're doing increasing data collection to support the what we call kind of pathways to durable solutions, and that's in support of the Secretary General's agenda on internal displacement. You may be aware, I don't know, this is very UN-centric processes, but there's essentially an action agenda for the next 2 years in 16 priority countries to try and reduce drastically the drivers of forced displacement and also reintegrate as many internally displaced people as possible. So IOM is part of that. We're trying to do more data collection on looking at where do IDPs stand on their trajectory to reintegrating the communities they wish to reintegrate, whether it's their communities of origin or a new community they live in. And so for that, we're going to stand up a lot more data collection capacity, doing household interviews, following groups of IDPs, etc. And one aspect, for instance, of the work that we do in Iraq with returnees from Al-Hol camp in northern Syria is to look at the element of reintegration into those communities, and the mental health and psychosocial support aspect of that is crucial for guaranteeing success of reintegration. And in the case of Cameroon, that aspect has also been central in terms of the way that we've engaged with particularly former associates of Boko Haram, and trying to provide them with those services as a means for reintegrating the communities they live in the far north.
I could add also that those services are provided in collaboration with local health authorities. And this specific project in Cameroon has a national officer for mental health and psychosocial support recruited through the IOM branch of the project. And within the WHO human resources, we have also recruited 2 clinical psychologists. So working those human resources for the project, working with the local health system, both at the health center and at the district level, and of course the support of the regional delegates for public health. This is how these services are being provided. Thank you.
We have a couple of questions in the room.
Any other question? There is some interferences.
Yes, we have a couple in the room here. I saw some hands up.
We can't hear anything. We can't hear you.
Here, now we have it unmuted, yeah?
Oh, yeah?
Yeah, the sound is not good and there are some interferences.
Yeah, can you hear us now? Or we're just walking up the mic to the participants.
Okay, now it's better.
Okay, can you hear me now?
You are 100%. We can hear you.
Okay, thank you. My name is Abdul. I'm from Niger Republic. I'm peacebuilding researcher and currently working with Search for Common Ground. So my question is related to the last question. How health activities is implemented in Cameroon context? Because we know in some countries in Africa, people don't really believe in mental health and mental diseases. So how it works in the practice. So this is my first question. And I have another question for Monsieur Ben Oumar. I don't know if I have to ask it in French or English. I will go in French. Je me demandais si ils ont commencé déjà à réfléchir sur les étapes après le projet. Est-ce que le gouvernement camerounais va prendre le relais pour essayer de mettre en œuvre les mêmes activités dans d'autres localités, ou bien est-ce que, comme d'habitude, ils vont attendre encore que des fonds leur soient donnés par un partenaire pour essayer, voilà, d'aller un peu de l'avant. My last question is for Mr. Kwame. Can you please give us a few examples of the activities you are doing, to reintegrate former child soldiers? Yes, thank you.
Great. I think the first one goes to WHO. So over to you.
Thank you. So the question was how are mental health activities being implemented? Do people trust mental health services? I must admit that Cameroon is no different from other African countries. There are people who are affected with mental illnesses, but Cameroon is blessed to have a very strong mental health program within the Ministry of Health. And this program has shown its value during COVID-19 and when we have some disaster situation. So as I mentioned, the project has recruited specifically for that reason people with mental health expertise. So I have mentioned that the IOM arm of the project has a mental health and psychosocial support officer who has this expertise. And from the WHO side, we have two clinical psychologists. So both of them are able to work with the local health systems to identify through their expertise people who need psychosocial support, who may be suffering from mental uncomfort or illness, and provide them with some support. So that's what I can say. If there is, probably I'll ask the coordinator to maybe share in an email some specific data related to that specific work. Thank you.
Thank you very much. Et je pense que la deuxième question, c'était pour vous, Monsieur Ben Oumar. C'était une question sur s'il y a déjà du réfléchi sur comment pérenniser le projet. À vous la parole.
Merci bien, Monsieur Abdul, pour votre question très pertinente. Oui, si vous avez suivi avec beaucoup d'attention mon exposé, la dernière étape de mon exposé évoquait vraiment ce mécanisme de pérennisation. C'est-à-dire le gouvernement de la République a défini une politique publique de décentralisation qui va permettre à consolider et puis à pérenniser les acquis. Donc, c'est une politique qui est en branle et qui n'aura aucun souci d'être implémentée après le départ des partenaires. Mais cela n'exclut pas aussi qu'on sollicite de temps à autre l'expertise technique des partenaires pour nous accompagner dans cette phase déterminante. Voilà, j'espère que j'ai apporté des éléments de réponse à la question de M. Abdou. Merci.
Merci beaucoup. Je pense que la troisième question était pour... Sorry, I think the last question was mine. I mean, the very short answer, and we can follow up because I know there's another question there. But essentially, according to the standards, actually, DDR is not for children because of international humanitarian law, international law. What we try and do at the negotiation stage is to get them to unconditional release. We work very closely with UNICEF, Child Protection Services, if there is a peacekeeping operation on the ground. So there's usually a section that deals with that. And then the process sort of looks like DDR, but it's not. It's there's 30 to 60 days of they're kept in a child-friendly zone. Family tracing is done. If not, there's pathways to orphanages, like we're doing in Haiti, like we're doing in DRC. The pathways are different depending on what they've been through and who they are. But essentially, we don't see them as combatants, so we don't even consider that DDR. We'll meet in the middle.
Any other question?
Just one more, I believe, unless two more.
Hi, thank you very much to everyone for the presentation. So, three very quick things. Number one, I'm Frank Brumfett. I'm a technical advisor with FHI 360. Probably the Cameroonian colleagues know this already, but we have a program in northern Cameroon called Programme d'appui à la résilience communautaire, which is also working in many overlapping communities. I would be very happy to make the contact between our Chief of Party in Marwa and your team. Well, I'm sure you probably have it already. Second, a kind of similar point with the IOM methodology for community action planning. FHI is doing very similar work. We have a presentation not on our work in Cameroon, but in other contexts. So if you guys are around, feel free to come tomorrow to that. And just to say, I think this is really, really interesting, the combination of all of those. My last kind of question on, the only real question, sorry, is on specifically on the DDR element in Cameroon. How is the project working with people in the process of demobilizing, and what does that look like? Thank you. Oh, and personal bugbear, I would love it if the faces of those kids were blurred or something, but you know. Thank you anyway for the great presentations.
I think that goes to the field, no? Okay, we can, otherwise I can cover that. Yeah.
Halfway as well. Right, wonderful. Thank you so much. Hello, if, okay, it's on, right? Can you hear me on this end? Okay, wonderful. Well, first, I just wanted to say thank you so much to all of you for the presentation and for the work. It's really incredible. So my name is Maddie Warman and I work with the Carter Center. So we actually are currently implementing a Peace Through Health project in Central Mali that's been going on for the last several years. So it's been really fascinating to listen to your presentation and hear how you've really overcome so many of the challenges with this cross-sector programming. So just kudos to start out with. Two questions, one that's broad and maybe difficult. What has been, if you could choose just one, the largest challenge that you think you faced in your work? One, and then the second one is specifically related to climate change. So you referenced that you're trying to consider it as a driver of forced migration and as a conflict driver, but have you started to think about how you're practically applying that or thinking about that when implementing activities?
Yeah, you want one? Not the DDR one, I can do that.
Yeah.
The one on climate change. Or was that you?
So there was one on climate change.
One on DDR.
Sorry, could you repeat the one on climate change? Definitely. Okay, so maybe I'll go with that one first, as it's fresh. So in northern Cameroon, but also in the east of Cameroon, on the border with the Central African Republic, we've seen a lot of the impact on traditional transhumance routes, and that's of course true around the Lake Chad Basin also. And so we've dedicated some of our resources that we have to collect data on the movement of people to actually track the movement of herds and how they've been altered due to climate change. So we've called that the transhumance tracking tool. And so for the Litago-Gourmand area in the Sahel and around the Lake Chad Basin, and we've had several projects on the border between Cameroon and Central African Republic, in Cameroon as well. And so what that data allows us to do is actually to look at these movements of herds, and then when they are maybe too large, when they happen out of the normal kind of season when the herds move, then we can communicate that data early to structures that are on the ground. We usually work with herder communities and kind of associations at the local level to then act on that data. And so that forms essentially an early warning system, and thereby we can try and have better planning of these changed then transhumance routes for that. So I could tell you more offline. Then there was the question in terms of our biggest wins. I think one of the biggest wins we've had is that there's a new policy being developed in relation to this project specifically, and on DDR in northern Cameroon. So that and with the National DDR Commission. So we're, but probably my colleague Kwame can elaborate a little bit on that. And we're working also on a gender strategy, responsive DDR strategy in northern Cameroon through another Peacebuilding Fund project actually, and trying to capacitate local civil society, women's civil society organizations there. And I think the other questions were for you.
Yeah, so just on the DDR side, again, good question, which I'm happy to delve into further on offline. But the project, as was described, has three major components. The second component, component 2, is around DDR. But specifically under that, two main pieces. One is on capacity building. I think at the very beginning we saw a clear need for strengthening capacity in the area of DDR practice for the National DDR Commission. So part of the project is focused on building capacity, knowledge exchange, connecting the DDR commissions to other commissions. We also flew them over to New York a couple of months ago to again, as part of this overall capacity building pillar. The second pillar is a bit more programmatic, and that has to do with the ex-combatants that have been identified that are coming out of Boko Haram, but also ex-associates, as they're called, who are in IDP camps, and there as well, there's some programmatic support to them. So that's what it, en gros, that's what it looks like there, but happy to give you more specifics later. I think we hit all the points. Unless there's anyone else online who would like to add anything.
Sorry, I want to add one element on the question related to mental health and psychosocial support. The coordinator has just given me a table showing the kind of services which are provided both to IDPs, the host communities, and ex-combatant. And the information is split between women and men, and also the area where the district or the health area where this is happening. And in total, for the period of implementation, over 1,063 people are benefited of this kind of services, mental health services and psychosocial support. 1,063 over the period of 1 year. Thank you.
I think that's it in terms of the questions here in the room. So maybe back to you, Doctor.
Thank you very much. I think we have had a very interesting sharing of the experience of Cameroon in this area of using health as an entry point, as an entry point for peace. And so in summary, in a very quick summary, we have had the context which I described, and also Liam added very useful information about what has been going on over the past 10 years about armed combatants, but also the issue of inter-community violence, which are related to the fight for resources, and the level of poverty in the region. We know that the poverty level in the far north is around 74%, where at the national level, this is about 37%. The level of malnutrition also is high, as well as low education level. We have insisted to the design of the project that it is a collaborative project between the government of Cameroon at all levels, with the highest support from the Office of the Prime Minister, but also the Ministry of Health and Ministry of Territorial Administration. At the regional level, a strong involvement and leadership from the governor, and at the local level through the administrative structure, and ending with the community entrance through the head committees. And within United Nations, we see a very good learning experience of strong collaboration and synergies between the Department of Peace Operations, the Office of the Resident Coordinator. We always insist about the leadership of the Resident Coordinator, IOM, you have seen the added value of these two organizations, and I'm pleased to list again the added value of the two organizations. For IOM, we are looking at a strong standing collaboration with national DDR authorities. We know that OEM is strong in understanding local community dynamics and tension, and also OEM has a robust expertise in community stabilization approaches. And WHO comes with a strong standing collaboration with the Ministry of Health, a strong understanding of health system organization culture, and expertise in health technical assistance. So that's how the project is designed, and also there is involvement of international organization. We see a potential of more collaboration within United Nations, particularly UNDP, which has a program of stabilization in the far north region, collaboration with HCR, and the WFP on addressing the issue of food insecurity and the Organization for Refugees. I will not go back to the objective. We have mentioned this. And so Liam highlighted the context and the prevention of forced displacement, essentially. And again, he's the one who reminded us the added value of the two organizations. Mathilde reminded us the Global Health for Peace initiative, and the experience in Cameroon is an operationalization of this initiative. We believe that lack of peace is a social determinant for health and development, and she showed the link between health and peace, which on one hand can be negative, such as leading to injury and death, but also could be a positive link, which can bring collaboration with between health professionals from both sides. She reminded us that we are actually implementing the humanitarian development peace nexus, and also addressing the implementation of SDG 3, 5, and 16. I will add 17 on partnership. Ben Umar highlighted the leadership of the government of Cameroon, again at different levels. He indicated particularly the role of the government of Cameroon in coordination. He highlighted the role of the COSA and also ended with showing the perspective for sustainability, particularly through the decentralization policy of Cameroon. I will add personally the initiation of the national plan for reconstruction and development of the Far region, which we will be welcoming very soon. He highlighted the role of the Prime Minister's office in the Comité de Pilotage, which is the steering committee, and also the role of the governor at the regional level. Finally, on the DDR aspect, Mr. Paku reminded us the link between peacekeeping and peace building through and the role that the health can play. He reminded us that peacekeeping relies on two arms: one on policy with the integrated DDR standards, and also on practice. And he also highlighted to us the 4 pillars on which the DDR policies and practices are built: the health strengthening, the health system strengthening as the first pillar, such as rehabilitation of the health infrastructure and health support for the health workers. The second pillar being the mental health and psychosocial support to reduce recidivism, but also the acceptance of ex-combatants in host communities. I like the comment by one participant who appealed to us to, before sharing the presentation, to blur the face of the children so that they remain anonymous. And the third pillar on health workforce, and finally the fourth pillar on infectious disease outbreak settings. So we had a very interactive and useful interaction with the participant, where useful questions were asked related to mental health and psychosocial support, and also the DDR project. And finally, we are all interested in the sustainability of the project. So I will end here and say we call for more support from the government of Cameroon, which is also a given. We work in a very conducive political environment where we are accepted, and we have a very good interaction with the leadership of Cameroon. So they will continue supporting the project, but also I call on us, United Nations, particularly the Peacebuilding Fund and the Global Health for Peace Initiative, to continue keeping Cameroon on the radar screen and help us move forward this project, and also beyond, maybe start thinking of phase 2 of the project. And with those few words, I wish you a very good afternoon, those who are in America. And for us who are in Cameroon, it is 8:45 p.m. So it's time to go and have a drink and have a good night. Thank you for the excellent conference. It has been a pleasure working with you colleagues from Geneva. I saw Kevin Usman, also from Geneva, who has been connected. The coordinator of the project was connected. So this has been a very, very useful discussion on this emerging important topic. Thank you and good night.